research interests are care studies, violence against health workers, structural competency for health workers, diversity competency in healthcare. She's a founding member of different initiatives about teaching medical anthropology worldwide. Margret believes in the need of medical anthropology for health workers' training and continued education and its usefulness for healthcare providers overall. She also serves as a mentor for Solar Plexus, an Austrian network that focuses on improving healthcare for all. Her most recent publications are about the anthropology of care from a paid care worker's perspective and women with endometriosis. Please, everyone, let's welcome Margret to our event today.
Thank you very much for this lovely introduction, Carol. Yeah, warm welcome from my side as well, here from Vienna, Austria, and it's a pleasure to be with you. Being the alien, this is how I felt for a long time, being very often the only anthropologist and the only medical anthropologist in a faculty of medicine, in a whole medical university, in teaching in health professions education. A little bit about the agenda for today. So I'll try to introduce you about what does it mean to teach in health professions education, how to navigate this, and some future aspects that I see coming up. I lobby for this topic since I've started teaching many years ago, and I'm happy to share my experience from the last years. So what does it mean, health profession education? You need to look at your home country or wherever you want to teach, what is a health profession there. It depends by country to country, and it's a highly regulated profession. So there isn't only medicine and nursing that might come up in your mind immediately when you think about a health profession, but in Austria, there are more than 20 health professions regulated by law. So you find surgery assistances, clinical psychology, clinical social work, physiotherapy, so many types of health professions. And there is an important aspect in that you need to know if you're allowed to teach as a non-health professional in health education, in health professions education. I am only a medical anthropologist. I'm not a doctor, I'm not a nurse, I'm not a psychotherapist. In the US, for example, there is an exam that's called the medical teacher, and everybody, even people who are not health professionals themselves, have to do this exam, and only then they are allowed to teach. So you need to have a look at that. For example, in Austrian nursing education, it's not allowed for most disciplines to teach for them if you're not a nurse. Is communication, I think there is ethics, but very few fit in the curriculum. So this is an important start. Next is the World Federation for Medical Education has updated its recommendations in 2020, and this is an instrument of power because for medical education, there is stated medical anthropology should be part of the curriculum. Every university in the world who wants to be internationally recognized wants to fulfill these recommendations because there are certifications behind that. There is a whole power structure. So in general today, universities feel a need to follow these recommendations. In the other health professions, it's different. I don't know about any such clear rule and any wording in any other rules of these international associations or unions that exist out there of different associations. And then it depends more when people, for example, write a new curriculum, if somebody gets interested, is aware of social sciences in a more broad perspective. And it often depends on individuals where you start lobbying and trying to make their head that anthropology, medical anthropology, other social sciences disciplines are important to have in curriculum. Next is networking. So if you're not in the situation that there is somebody telling you, oh, I need an anthropologist to teach something in my curriculum, then you need to network with health faculties, with practitioners. You need to probably build up a strategy. What do you want? Do you want a job? Do you just want a little teaching experience? What's your vision behind all that? And then go out and try. LinkedIn might be of help. Depends on the region, depends on how people are using it. You can build, of course, your own strategy on LinkedIn as you as a person and to marketing for medical anthropology, for example. My experience is also that many anthropologists start teaching qualitative research methods in such health professions education or even scientific writing. This might be a door opener for you. And later, as it was for me as well, tell them, oh, you look, but I'm an anthropologist and I could offer this and that. You could get in contact via conferences, ask friends, whatever helps you. What to teach depends on the curriculum. For me, it's important that you remember that you don't need to invent the wheel. People are doing this since decades. So look up in the internet, talk to your colleagues, copy from others. Other people have experience which texts were working well, which methods you could use to teach, to engage people. So don't spend too much time on trying to invent the wheel again. Go the easy way, I would say. The doors that open, go there. It might not be in the medical faculty, but it might be occupational therapy. How to navigate later, there is undergraduate, postgraduate, and continued education programs in and outside academia. Don't forget about the spaces outside. Hospitals have continued education programs. And this fits then later going to Mirko's talk. There is also in some universities the chance to teach multi-professional classes. Who can help you also to navigate this is different initiatives. The one that exists very recently. We are called the Health Professionals Education Special Interest Group of the Society of Medical Anthropology. You find here the link. This might be a community for you if you want to start teaching or if you are already teaching, as well as the Behavioral and Social Sciences Teaching and Medicine organization based in the UK. They are also very open and they have monthly meetings about topics and the conference, or go to interdisciplinary conferences. What you need, and this is my experience from the last years and also from developing a train-the-trainer project for people to teach, you need to know how to write cases. Medical education, for example, is all about teaching in cases. Students are used to that and it works well. And we need to find our own way, and ours look different than the ones they are used to. You probably need some training about the local healthcare system, information about the curricula, and also interprofessional collaboration. These things depend on laws, on national resources, of finances, but also staff. We have a huge staff shortage, for example, in nursing. You could do, if you're allowed to develop something on your own, to put in some curricula, do a course development and syllabus writing training. What I also can say from my experience for today, there is no good handbook for teaching medical anthropology to health professionals at the moment. I'm involved in this since longer, and the experience from my colleagues and myself is that we are collecting good texts and good examples, but there is currently no handbook. Iveris Martinez and Dennis Whitman from the US published their collection of anthropology in medical education in 2021. There are international cases in there. It's not only US focused. Have a look at that to get an idea what it's about. And Andrew Russell from Durham University, UK, published The Social Basis of Medicine in 2009, which is used in medical teaching in the UK. But I think it wasn't updated so far. Also to have an idea of what people are teaching. Also the Antro Career Ready group, for example. If I have a look in the future, I would say university managed as a term from management side of human resources and project management may help you, because this is where our anthropological knowledge could be valued and where we can add something. Interprofessional collaboration and education of health professionals. using our anthropological theories and skills as an asset has helped them to improve this teaching, and also, for example, looking outside the academia and the undergraduate and postgraduate education, but when it comes then to continued education, which is for health professionals mostly provided outside academia, or as I learned from Carol in Australia, it's in special physicians colleges. Also think of that as one possibility where you could start offering. And here we come to the end. You have my teaching experience here, but you can read through if you like. At some time, we are offering this later for you as a presentation. And I thank you very much for your attention. And we are happy if you join our group, and I'm happy for the questions later as well. Thank you.
Thank you so much, Margret. This is really important information for all our attendees. I'm sure that they really appreciate your expertise. And before we start with the Q&A session, our second speaker, Mirko Pasquini. So even for Mirko, a brief presentation. Mirko is a postdoctoral researcher in medical anthropology at the Center for Medical Humanities at Uppsala University in Sweden. His research interests combine hospital ethnography and primary care in Italy and Sweden, with a focus on the social dynamics of attention, trust, and mistrust in care interactions. Mirko's book, The Negotiation of Urgency, Economies of Attention in an Italian Emergency Room, is currently in press by Rutgers University Press. Since 2018, Mirko is engaged in health workers training in structural competency in Sweden and in Italy, and is also an active member of the SMA Special Interest Group on Teaching to Health Professionals, a board member of the Swedish Anthropology Association, and he also coordinates the hospital ethnography peer meetings within the MACE network. Thank you so much, Mirko, for being with us today, and please. Go ahead.
Thank you so much, Carol, for the very generous introduction. And thank you so much. And can you all see my slides? Everything is working. Can you hear me? Perfect. So as Carol was saying, I have been teaching for quite a while structural competency to health professionals, and mainly was within programs of continuous education within the context of Italy, particularly in Emilia-Romagna, collaborating with the regional healthcare authorities and different kind of hospitals from Bologna to Modena and Reggio Emilia. And then I've been bringing the same courses readapted to local problems and understanding of, what are the problems that health professionals encounter every day within their clinics into places like Sweden and different places within Sweden. So what I have been doing in practice is readapting something that I found basically in the fieldwork. The structural competency, there exists a global network of structural competency, and it aims to provide instruments for analyzing and reflecting upon the structures that determine health. And I think probably you have seen this schema that basically is a way to portray how health it is determined and how health is influenced by structural determinants of health. And what I have encountered in the ER is a lack of understanding when it comes to these structural problems, when it comes to physicians and nurses and all the different healthcare providers. At the same time, these problems were actually taxing upon their work. So they didn't quite realize, they didn't have a vocabulary to actually talk about it. But at the same time, this was extremely, the influences were very, very strong within their work. And I have been working in an ER especially, and there in ER, we have to imagine that episodes of mistrust, violence, or overcrowding are absolutely very much frequent. And what happened there was that most of the time, the one who actually got blamed were the patient themselves. So there was never the step from individual responsibility to the structural level to actually see the clinical work as also a way to tackle structural problems. And so in order to do that, I started teaching structural competency within these continuous education programs. And I have been teaching about in different format, in proper courses or intensive courses of 2 days, like 12 hours or 18 hours, according to the different kind of hospitals and the availability of healthcare staff as well. So what I've been trying to teach them during intensive course is to recognize structure but influenced by clinical relations, but influenced by work directly, to develop an extra clinical language to understand structural influences, and basically to have the possibility to understand extra clinical languages and have an idea of how we can make sense of structures through other kind of anthropology-driven languages. Rearticulate individual action on the basis of structural determinants, imagine structural solutions, and also develop an understanding of their own positioning as physicians and nurses within a highly hierarchical structure like a hospital. So all of this in order to actually have a practical impact within the clinical relation. And I'm going to show you how I have done this on the very basis of ethnography itself. So using the cases drawn from my ethnography in order to use them as pedagogical tools. So one of the things that I was aiming at is also to unpack culture in structural terms. Because one of the problems when usually anthropologists are invited in the hospital, what they usually ask you is to deal with, the other, the cultural competence, and how do we deal with migration and the problematic different cultural understanding. But after a while, of course, I tried to show, being in the field, how culture is continuously shared and is a process that is processual and is not static. So it's not something that everybody has, but it's something that is continuously changes, and how culture is structurally driven and it's not enclosed, but it's permeable. And it's, of course, something that gets naturalized through a process called embodiment. And in this sense, after a while, by showing them how the different structure of social structure actually impinge upon their practice, they actually realize that what I was actually doing is showing them how the social production of difference works. And I'm going to show you in practice how I have done it during the courses. So on the base of practical cases, I have been working with practical cases that are drawn directly from ethnography. And on the base of ethnography, I used that as a pedagogical tool to show what can be done differently. First of all, to recognize the structures that impinge upon people's health, and then thinking through those structures, what can be done differently. So this first part, of course, the names are changing. Omar, I've met Omar in the ER, of course, has a different name, but these are just the part that are revealed within the ER encountered. So Omar was found unconscious on the street and taken to the ER. He becomes an alcoholic, gets assaulted, and lives on the street. He has a migration background, and that's all that they know because of the kind of questions that are asked in the ER. Being an ethnographer in the ER and having the time to be in the waiting room and actually ask different questions to Omar, I discovered that Omar dreamed to migrate from Africa to Norway to join his cousins. After 2 years of travel, he reached the coast of Lampedusa. He's rejected as a political refugee in Italy because of illegal migration policies, and he collects fruits and vegetables 12 to 14 hours for €2 a day. So he escapes to northern Italy, and then he works on call without a contract in a construction company. Then he falls from a scaffold because he doesn't have a helmet, and he cannot work and gets fired, and he cannot pay rent and send the money to his family. So then we have a different kind of understanding of what's the situation of Omar and why he's constantly coming back to the ER for problems, for alcohol, for the fact that he doesn't have a place where to live. But because of, one of the things that immediately healthcare workers would say is that, okay, but what can I do about this and why is it important? And also, it can be just a person that is particularly unlucky. Because of that, I try to show them that it's actually the social structure that impinge upon Omar's situation. So I make them aware of inequality between north and south of the world, the migration routes and violence, but it affects directly Omar's health, and the organized crime and exploitation, the national and European border politics that affect his health, the work exploitation and tax evasion, no work security measure, and the lack of welfare and right to housing. So then the target of the clinical intervention is recrafted towards structural problems. And of course, the immediate effect that you have when you teach something like this is that you completely destroy their sense of agency. Because, what can I actually do to solve work exploitation, to address that within a clinical setting? So the real challenge after you have shown that is that first, making sure that they actually understand that also within the influence of social structures. So in order to prevent them to say that, okay, this is, an unfortunate problem, but it may regard migration issues and people that are particularly unlucky. Actually, then what I do to prove them wrong about this is to reverse the lens towards them, basically. So Ludovica, which was also an pseudonym, was a person working in the ER. And she also has been having quite some problems in relation to structural forces. So she decided to study medicine to alleviate the suffering of the poorest after volunteering. She had limited opportunities to understand the social determinants and the context that arises from which pathologies arise. So she doesn't understand what is outside the clinic. She does not know how to relate with patients in the ward. She's not given effective tools to understand street life or addiction. And she has a decline of empathy towards patients. Her internship during the internists during the internship do not calculate her. She enters medical training, a residency, and understaffed department where new hires have been blocked. So she's constantly precarious. She goes to lunch with an old friend, and who has already finished the specialty, and now is a general practitioner only because you earn well and you do few working hours. So there's a different kind of logic, which is not the one that is in relation to care, but it's about limiting one's own effort. So when she gets burnt out and has an average time for each patient of 10 minutes per visit, she has lost interest in her work, and now she's just trying to survive on a precarious contract. And she calls patients by pathology because she does not remember their names, just looks at medical records and avoids talking to them directly. She talks directly to the computer. And she provides care far below optimum standards. And of course, the same trick that I have been using with the other case, I use it in this case as well. So no extra hospital training and focus on social determinants, the absence of social and relational competence in medical curricula, only biomedical focus that hinders, the possibility of people to actually understand what is going on, no precise training, responsibility, and duties, and the lack of organization within certain kind of hospitals, and the financing of the public service. So this basically twists the lenses towards the structural level. So the problem that then you find yourself in when you teach these kind of things is how to recuperate a sense of agency for them. And that's the next phase of the course. So I've showed you through the cases as well, but through asking different questions, you can discover different things, which are extremely relevant within the clinical evaluations. So you can actually know why people come back constantly in the ER. And it's not because of their individual choosing, but because of structural relations. So sharing strategies to build trust between peers, to create networks and understanding how relations and trust are actually important in this work. And the temporal hinders and their effect on interaction. So why do I have to have just 10 minutes? And the iatrogenic effect upon this of bureaucracy and standardization existing in hospitals. And this is always a way to reimagine also physical space and within dialogues. For instance, the communication of death is a huge problem when it comes to emergency rooms. This is usually done in isles without any proper space where to communicate this. And how to improve or build relation with others, healthcare service and local community associations. And this is key, of course, to have a network of community association in order to face challenges which are broader than the possible clinical intervention, but have to be tackled within the clinical realm. So to do that, also there exists different kind of questions that can be asked. What work do you do? How much do you earn? Where do you live? Do you live with anyone in case you have the possibility to have help? Or what's your relationship with your GP, as the GP is the key person to access healthcare and different kind of services? And what do you do in your free time? So to have also an idea of social relationships and how people can be kept healthy. So concluding, I'm trying also to foster a different kind of vocabulary, again, to allow them to imagine how things could be different. And this is some example of different kind of vocabulary that I have been introducing in the course. So of course, this has problems too. And have to do something like this, you have to have a very in-depth knowledge of clinical structures, a very in-depth knowledge of local resources and NGOs, and mapping civil societies initiatives. And the mapping becomes an activity that you can actually use to create a referral network that can be then used and taught within these kind of courses. On the other hand, also there are bright sides because ethnography, so on the base of fieldwork, this can be implemented. So ethnography can actually work as a pedagogical tool, as an applied pedagogical tool in this case. And the difficulty is always, of course, to make local a knowledge that has also been standardized, like structural competency itself. So thank you very much, and look forward to the discussion.